Well, good afternoon. My name is Lizette. I'm an occupational therapist by background and training. I have been in the United States going on 28 years. My husband and I are originally from South Africa, so you may pick up an accent every now and then. We live in Greenwood, South Carolina. It's about 70 degrees outside right now, so probably a little cold, a little cooler than Houston maybe, but I'm still wearing short sleeves. So I'm enjoying my fall weather. My background is pretty varied. I have worked all over. The first several years we moved to the United States, I worked as a traveling therapist. So I have worked in skilled nursing facilities, in acute care hospitals, in rehabilitation hospitals. I have worked in outpatient settings, and then primarily right now I work in home health. So the reason for this topic, and that I think I'm a good person to speak to this, is I've actually seen all of these different settings and what it means for people when they're coming in at each of these different steps along the continuum of care. So I thought I would speak a little bit more today using some case studies, some real life situations that have happened that I've seen every single day in all of the different settings. And I'm going to try to break it down into little bite-sized pieces and try to give you guys actionable things that you can use to be able to define things so that when you have a loved one that is in the hospital and they say one thing, the doctors and the people in the hospital mean one thing, and we as care partners or care versus care providers, the staff, I think we're not always speaking the same language. So hopefully some of what I'll be able to do today is give you guys ideas or clues as to when they're saying this is the follow-up question I want you to ask. So the case study, the example that I wanted to start with today, because this is something that happens frequently, that happens every single week, and happens with people with dementia and can be very confusing, is a urinary tract infection. And so I've got a couple of examples in my head that I'm going to be speaking through. But when I, as an occupational therapist, am working in a hospital setting, right? So we have a hospital here in Greenwood called Self Regional. And when I'm working in acute care in the hospital, and I get a referral from the doctor that says occupational therapy, evaluate and treat. What the reason the doctors are giving those orders for physical therapy and occupational therapy oftentimes in the hospital setting is because the hospital is a clearinghouse. And the therapist's job in the hospital is to be able to go and say, this person can go back home, this person needs more help, and we think they need this level of care of help, or this level of care of help. So the therapy orders in the hospital are not necessarily there to improve a person's function, because a person's not usually in the hospital long enough for us to truly improve their function. Now, sometimes, yes, there are exceptions. I've had people in the hospital for 6 months. That happens too. But if you think about a hospital, what's a hospital's job, right? A hospital's job is to try to get people in and out as fast as possible. That's what a hospital does. It does not want people sitting on their expensive real estate, which is a hospital bed. Okay, so when we have a loved one who is living at home who has dementia, and they are still independent, they may be just requiring a little bit of help with some of the higher level things, like maybe reminding them of their medication or grocery shopping or some of these other higher level stuff, but they can still take care of themselves. And then boom, they get to become cuckoo for Cocoa Puffs, and they're admitted to the hospital and they have a urinary tract infection. The very first thing that you have to think about is, just because a person is in the hospital, the physical building of a hospital, and we think that because they're sleeping in a bed in a hospital that they've been admitted to the hospital, that may or may not be true. Okay. And what do I mean by that? There are two types of hospital admissions, and every person is either a full admission to the hospital, or they're what's called outpatient in a bed. Okay. And depending on which one of these two a person's classified when they come into the hospital, starts a cascading event or domino effect regarding levels of care that are available to them each subsequent part. So the diagnosis urinary tract infection is not a diagnosis that typically requires a full hospital admission. Okay, so frequently people who have these types of diagnoses, like a urinary tract infection, or something like a kidney stone, or just some general medical stuff, total shoulders, which totally blows my mind because that's a whole nother story. But there's certain diagnoses that Medicare has decided these are what are considered outpatient in a bed procedures. Okay, so if you're outpatient in a bed, that doesn't mean even if you've been in the hospital for 7 days, if they didn't convert you to an inpatient acute stay, which is the other classification, you don't qualify to go to certain types of rehab. So just because a loved one is in a hospital bed does not mean that they have been what we as the medical professionals call an inpatient admission. So families are walking around, mom's in the hospital, mom's been in the hospital for 4 days. She was admitted because they put her in the hospital, she's not at home. But in our language in the hospital, she's not really a full admission in the hospital. She's under a diagnosis group that's called an outpatient in a bed. Now, why is this important? It is very, very important because there are all these different buckets that people have, buckets of benefits, and I always call them little buckets of benefits under their Medicare. And we're just going to talk about Medicare proper because insurance, and I understand some people may have insurance and so on, and each insurance is going to be different depending on what the insurance policy says. But Medicare is an insurance policy. Yes, you need a good case manager, absolutely. So when you think about your bucket of benefits, a person typically with Medicare has Medicare Part A and their Medicare Part B bucket of benefits. But under your Medicare Part A bucket of benefits, you have your hospital benefits, your acute hospital benefits. Medicare Part A also covers home health benefits, which is another bucket. So we have the hospital benefits, we have the home health benefits. Medicare Part A covers hospice benefits, which is another separate bucket of benefits. Then we have another bucket of benefits, which is so we have inpatient acute care, rehab bucket of benefits, which is a totally different bucket of benefits, but it's under Part A benefits, but these are all different little buckets of benefits. So when you have a good case manager, when you have good therapists working with someone in the hospital, part of what we're trying to do is use their benefits to the best of their the benefit of the person who's entitled to those benefits. So sometimes when we're not able to make a recommendation for one thing, we're making another recommendation because they don't qualify for the other thing, that even though we think that would be better, but they don't qualify for that. So a person who is under observation in a hospital and they've not been admitted. So think about my person with the urinary tract infection that we were talking about. So she was living at home, she was independent, and now she's cuckoo for Cocoa Puffs and she's admitted into the hospital. But the first 3 days, she's under observation in the hospital, which means even though she's had 3 midnight stays in the hospital, she doesn't qualify to go to a skilled nursing facility, because the rules and the regulations for skilled nursing facility mean that you have to have a 3 midnight stay admission to the hospital. So they've been observation, they've not been admitted. So they didn't qualify to meet that threshold of being in the skilled nursing facility. So I don't want people to get afraid when they hear the words skilled nursing, because skilled nursing has 2 sides. Skilled nursing always has 2 sides. You have your short-term rehab skilled nursing side, and then you have your long-term care skilled nursing side. When a person is admitted to the hospital, so now I'm talking about a true admission, they've had their 3-day midnight stay, okay? So they are now qualified to go to, and the case manager comes in and says, we think your mom needs to go to a skilled nursing facility. What the case manager is actually in essence saying is she now qualifies under her Medicare Part A benefits to go to a skilled nursing facility for rehab, not necessarily long-term care placement. They're 2 totally different things, okay? So a person has to have the 3-day midnight stay in order to qualify to go to a skilled nursing facility for the short-term rehab. So short-term, many years ago, I've been in the United States going on 30 years. When I first moved to the United States, skilled nursing facilities were really truly just for long-term care. It wasn't for short-term rehab. And then because short-term inpatient acute rehab, which is a different bucket of benefits, and I'll explain them in a minute, was so expensive to have people go to, Medicare decided to allow facilities, and they're called different things. They're called transitional rehab units, which is another word for a short-term rehab stay, but it's under your Medicare Part A skilled nursing benefits. All of these different words, like a swing bed in a hospital that sometimes we have some small regional hospitals that have a swing bed. So they've converted one of the hallways in the hospital. They fall under the Medicare nursing home guidelines. And these people that are in those beds are considered the swing beds. So they fall under your skilled nursing guidelines. So for straight up Medicare, I'm not talking about Advantage plans and all of these Medicare replacement, because each one's different. They're supposed to follow Medicare's guidelines, but they are still separate insurance policies. So you have to know what your insurance policy says. But if you're straight up Medicare, traditional Medicare, and you've had a 3-day midnight stay, and you qualify to go to a skilled nursing facility for short-term rehab, for the Medicare pays the first 20 days at 100%. So the first 20 days of your room and board and therapy, everything is covered at 100%. Then Medicare kicks in and pays the last 80 days. You get 100 days per episode of care. The last 80 days are paid like a co-insurance, where Medicare pays 80% and you get to pay 20%. So you have a 20% copay, okay? So when we have, back to our little lady who has the UTI and is admitted in observation, observation status in a bed, and she's been there for 3 days, and now she gets septic and she has pneumonia. Now she has a diagnosis that allows her to become a full-on inpatient admission. So when we have the full-on inpatient admission, to the hospital, that starts the clock for her 3 days admission to then be able to qualify to go to the skilled nursing facility for additional rehab. So when I'm working in the hospital and I have these patients that come in and they have an underlying dementia and a urinary tract infection can like that make a massive difference in a person's thinking processes overnight. And I'll go and I'll do my assessment and I'll say to the family member, because I walk in and mom's not following any commands at all, whatever, nothing. And I'm like, the chart says that she was living home alone. She was still driving. I don't see that. How is that possible? And I talked to the family and they're like, yeah, a week ago, mom was driving. She was paying her bills, all of this stuff. Then I know that if I walk into that person's room at that time, that they likely now have one of two things have happened. Their underlying dementia, they have had an underlying dementia that now has the UTI that's caused the delirium on top of the dementia. And it's going to take anywhere from 3 to 6 weeks for me to figure out whether or not her cognition is going to clear up enough for her to be able to live home alone again. So I know when I go in and see that particular person, we better have a plan, because they are not going to be able to take care of themselves the way they were prior to their having a urinary tract infection and then getting all of these other things start to happen. So unfortunately, a urinary tract infection, unless it has a complicated course, is not actually a diagnosis that admits you to a hospital. You have to have something else happen on top of it. You have to have things like acute kidney infections and injuries and things going on, or you were septic that put you under an admission status in the hospital. And there are lots of diagnoses like that. So when your loved one is in the hospital, taken to the hospital, EMS comes, you took them to the ER, whatever, and they say to you, we're going to admit them to the hospital. The first question you have to ask is, are they being admitted or are they an outpatient in a bed? You have to, I beg people to find that out, because Medicare is the one that decides whether or not a person is observation or outpatient in a bed or an inpatient acute admission. Medicare's guidelines delineate that decision, but the doctors do have some leniency and ability to make decisions regarding that. And so sometimes by just being aware that you're aware means that they will actually admit them to the hospital and not just an observation status. I frequently see in patients' charts, all hospitals have a review system, have a reviewer, a medical reviewer who's a physician who will be going through still saying, this person does not meet criteria for inpatient hospitalization for whatever the reasons are. But squeaky wheel does get the oil. So don't be a pain in the butt. Honey does go a lot further in a hospital. If you want to get the best service you can in a hospital, be the sweetest patient, be the sweetest family, be the ones that are always trying to make the jobs of the nurses and the doctors and the CNAs and the PCTs, whatever names, the therapists, all of them, make their jobs easier. Don't be the family that's, heck on wheels, because nobody wants to go into that bedroom. Everybody's trying to avoid that room because they've, so you want to be an advocate for your family member, but you want to do it in a very sweet, soothing, calm, collected way. And if you don't understand something, say, I don't understand what you just said to me. Can you explain it to me in a different way? Because medical people are smart, but they're stupid. They really are. We know what we know, so we think that we're being clear, and we're not. And so and when you're on the recipient side, you have so much information coming at you the whole entire time. There is no way for you to know. Hang on, I got to scream at my cat. Sorry, he was scratching my couch. I'm like, don't scratch my couch. That's bad. So anyway, sorry about that. Right in front of me too. So be your loved one's advocate, but do it in the right way. So a urinary tract infection typically is not considered an inpatient admission. It's observation, which somebody asked a question, observation versus outpatient in a bed. Yes, observation and outpatient in a bed are the same terminology. And the doctor decides, and CMS, and then the doctor decides whether or not a person is a full admission to the hospital or not. So a caveat to that is, so we talked a little bit about, being able to go from an acute hospital to a skilled nursing facility. One of the other buckets of benefits, though, that is available to a person is an acute inpatient rehab facility. That is a separate bucket of benefits. Well, its rule set is totally different than skilled nursing. You actually do not ever need to be admitted to the hospital in order to qualify to go to an acute rehab hospital, okay? They're different hospital systems, but they are very diagnostic specific. And what I mean by that is the diagnosis drives whether or not a person qualifies to go to an acute rehab facility. The kinds of diagnoses that more likely automatically qualify are things like a stroke, a spinal cord injury, a head injury, Parkinson's disease, all of these neurological types of things, Guillain-Barré, Lou Gehrig's disease, think neurological. Then there are amputees, rehab diagnoses, needing physical therapy, occupational therapy, and speech therapy, and 24-hour nursing care. So that's what qualifies a person to go to an inpatient acute rehab. They have to have the need for that. So the rehab diagnoses typically are the neurological types of diagnoses. Then you have 25%. They may have changed the case index, how much percent can be other diagnoses, but they can take other diagnoses, but they have to always keep these two percentages in alignment. So if they don't have a lot of these, they cannot take a lot of those. The kinds of diagnoses that also qualify are things like a fall and a fracture that resulted in a person having a hip surgery, like an ORIF, open reduction internal fixation of their hip. That can sometimes qualify a person, especially if they have a comorbidity like Parkinson's or dementia or some of these other things. The caveat to that is they have to be able to tolerate 3 hours of therapy per day. And so when a case manager walks into the room and says, the therapists are recommending that your mom go to rehab and she needs to be able to tolerate 3 hours of therapy per day, everybody goes like, oh, that's too much. Well, yes, it would be if you're going to make me do it 3 hours consecutively. We're talking about 3 hours of therapy from 7:30 in the morning until 5 o'clock in the afternoon. So what that looks like in an inpatient acute rehab facility is, so say my little lady with a UTI, she was admitted under observation, and then something else happened and she got pneumonia, and the therapists came in because she was cuckoo for Cocoa Puffs, and they felt that she could tolerate and qualify to go to rehab. And they come in and say, we want your mom to go to rehab, acute rehab. And then the case manager comes in and says, they've got to tolerate 3 hours of therapy. And families like, they can't do that. They can barely sit up on the edge of the bed. What that 3 hours is divided up between all of the different types of therapy that that person's receiving. So say they only have physical therapy and occupational therapy, they would get an hour and a half of each. But that hour and a half is spread out over the day. So I would go in at 7:30 in the morning and I would maybe see them to help them get dressed. And that took 45 minutes. Well, that was 45 minutes of therapy. And then they would go to the dining room. And after that, they would go to physical therapy, and they were maybe only could tolerate 30 minutes. So they had a 30-minute session in the morning. They put them down for lunch, to rest. We get them up again at lunchtime. They go have lunch. And then after lunch, they have another hour of physical therapy and another hour's rest, and then 45 minutes of occupational therapy. They got 3 hours of therapy that day. So the rehab hospitals are very good at making sure they meet that 3-hour threshold. And they also have some rules that are, behind the scene rules that they can work with a person to get them up to that 3 hours if they cannot tolerate it day one when they come in. So acute rehab is a separate bucket of benefits available to a person when they've gone to the hospital. The difference with acute rehab, acute inpatient rehab, the 3-hour therapy rule is you don't actually have to have been admitted, full-on admission to the hospital, and you don't have to have a certain amount of days that you were in the hospital in order to qualify to go. It's more diagnostic driven, it's more diagnosis driven. Versus the skilled nursing facility, you have to have 3 midnights, and it's less diagnostic driven than going to an acute rehab. But they're 2 different buckets of benefits. Sometimes what happens is we'll recommend, acute care therapists will recommend a person. So we'll say mom has a diagnosis of dementia, but she's doing pretty good. Now she has a stroke. Okay, so she ends up in the hospital. She's admitted to the hospital because she's had a stroke. And the therapists come in, and she's had what I call a humdinger of a stroke. And she really is going to need a lot of rehab. She's going to need a lot of therapy. What we typically would try to do first is get her into inpatient acute rehab because it's a separate bucket of benefits. And so we want her to use that bucket of benefits first because it's harder to get into rehab from anywhere else. You can, but it's harder than from a hospital. If you can get into a rehab hospital, an acute rehab hospital, straight from a full-on admission in a hospital, medical hospital, then it's a straighter shot. You can go from skilled nursing to acute rehab. You can go from home to acute rehab. It's just hard. You got lots and lots of hoops you've got to jump through, and you've got to fight for those benefits. So mom had a humdinger of a stroke with an underlying diagnosis of dementia and was pretty independent. I'm going to try to get her to acute rehab first, tolerating 3 hours of therapy a day for as long as we can keep her there because it's a separate bucket of benefits. If she's not ready then to go home, I know I can drop her into the other bucket of benefits because it counted for those 3 days midnight. She would qualify to go to skilled nursing for continued therapy for up to 100 days. So the up to 100 days is as long as the person is continuing to make progress. So not everybody reaches that 100 days, but people, and sometimes depending on their Medicare benefits, if they don't have a supplemental insurance that pays the copay, sometimes people will only stay in the skilled nursing for 20 days because that's covered at 100%, right? So if they're covered then at 100%, but say they have AARP or another co-insurance, now we can keep seeing them. So we've maybe had mom was in the hospital, had an acute stroke. She was there for 7 days. We got to keep her in acute rehab for about 3 weeks, 3 to 4 weeks, whatever they can keep her. And now we've stretched another almost 3 weeks of acute, more intensive therapy at the skilled nursing before I have to make a decision. What am I going to do? Can I bring mom home? Will I be able to take care of her at home? So That's acute care, that's the acute rehab. Then we have the hospice benefits that nobody wants to talk about, but we've got to talk about it because it is a wonderful benefit. So I'm going to use my little lady with the urinary tract infection who had some underlying dementia beforehand, but she really had a humdinger. And I have seen this. I have seen people never come out the same again after a urinary tract infection. And she was observation in the hospital. Something else happened. They did make her inpatient. She didn't qualify to go to rehab, acute rehab, and we get her into a skilled nursing facility, but she's not bouncing back as well as we had hoped. And now we're looking at, she's made no progress. So the therapists are coming in and saying, unfortunately, despite everything we've tried, and when I'm working with people like that, I'm trying to buy them a minimum of 3 to 4 weeks from the change of environment, knowing they had dementia. I'm trying to get them 3 to 4 weeks. I will do everything I can to try to keep that person on my caseload for about 3 to 4 weeks to see if the confusion, the delirium from the UTI will clear up. If at that 3 to 4 week period, the person doesn't clear up, we have a decision to make. If they're not at a point where a family member can take care of them at home, then are they going to stay in the nursing home and then transition to long-term care placement, which is where, hopefully throughout this process, case managers and social workers and these people have been talking to you about what's going on, because it never should be a surprise. If it's a surprise, we haven't done our job. I tell my people, I'm very direct. People don't always appreciate it, but I can't help you if I cannot tell you. If I'm too afraid of hurting somebody's feelings, I really cannot help them, because I need you to be able to be prepared. So I would go in and say, this is what I'm planning on doing. I'm hoping that 3 to 4 weeks from now, we're going to be here. But if your mom isn't at this point in 3 to 4 weeks, then maybe we are going to have a conversation about hospice or about palliative care or long-term care placement. So don't be afraid to have those conversations. You have to have those conversations early and often. Never in the continuum of care should it be a surprise to you that something is happening. Sometimes, though, it is a surprise, or it feels like it's a surprise to us because we're not ready to hear the information. So and I know this to be true because I can imagine, like my dad, I'm helping my dad. My dad doesn't hear 3/4 of what the doctors have said. And I'm like, I know they said this to you, because I'm there. I know that this information, but he's not at a point where he can hear the information. So sometimes healthcare providers don't do a good job of explaining it the right way, but sometimes care partners are not at the right place to actually hear the information, and it can take weeks or months because nobody wants to hear that, unfortunately, I don't think your mom's going to get any better, right? Nobody wants to hear that. I don't want to hear that. I wouldn't want to hear that about my husband, about my child, about my mom, about my dad. I don't want to hear that. But unfortunately, sometimes there are things that happens that means somebody's not going to continue to make better. Hospice is something that I don't want people to be afraid of, because hospice can provide you so much. They can give you a nurse's aide that can come out and help bathe someone. They can give you a nurse to come help check medication. They can help with some supplies, some incontinence supplies and those types of things. So don't ignore hospice as a bucket of benefits, because that's what it's there for. We wait way too long. We wait way too long to start to access that because people are afraid of hearing the word hospice. They think somebody's going to pass away. I've had people on hospice for years. And so it's just another way of providing care for somebody at home. So say back to my little lady with the UTI. She's not as bad. She came in. She was observation in a bed, outpatient in a bed, observation status, and the therapists think that she can go home. So now in that scenario, the clearinghouse decision becomes: can I go home alone? Do I need 24-hour care? If I need care, can my children provide it? If I need a nurse and physical therapy and occupational therapy, then home health becomes the bucket of benefits that I want to pour them into. Because under home health, and we're going to talk about home health and Medicare Part B and mobile Part B, which is something that's a little bit newer. Okay, but let's just talk about your home health benefits for medical stuff. So mom went to the hospital. She had an acute UTI. They changed a whole bunch of medicine while she was in the hospital because of the medication changes and all of these types of things. And she needs physical therapy and she needs occupational therapy. And for good measure, she was having a hard time swallowing. So now we threw speech in. So that person more likely would go home under their Medicare home health benefits, which is where I work right now. So what do I do in that setting? I go into the house, and my primary function as an occupational therapist is to try to, first of all, make sure that the environment is set up for her. Does she have the right equipment that she needs for her diagnosis, for her aging in place? If I know somebody's going to stay there, I look at the whole house, the whole setup, making sure that we make recommendations to keep that individual home at safe. But I also know, because mom has a history of dementia, I'm asking all sorts of other questions because dementia is my specialty. That's what I live, eat, and breathe, and do. And so I'll be asking questions. How does your mom manage her medicine? Is she forgetting to take her medicine? What about bill paying? Oh, no, we've taken over the bills. Mom's not got dementia, but we took over the bills 5 years ago. Light bulb. Why did you take over the bills? You don't take somebody's bills away from them unless you start to notice that they're having trouble. So even though people cannot necessarily verbalize that we noticed 3 years ago mom is having trouble with her thinking, we know mom's having trouble with her thinking because we took her finances away. So I'll be asking all these background questions so that I can start to educate the care partners regarding what we're doing now. And then I also start to bring up conversations about palliative care for later on and those kinds of things, because I want people to be prepared. Unfortunately, dementia is a progressive thing considered right now. And so I want us to be more proactive and not just wait until things happen. But so that's your home health benefits. The nice thing about home health is if you have the right home health provider, you can have a medical social worker come out. So that's another way to get a case manager in. That's another way to get a case manager in to look at a person's resources so that you can manage them the best way you can. You can get physical therapy, occupational therapy, nursing, speech language pathology, and a home health aide. So sometimes a person comes home pretty sick and we can throw the whole rehab bucket at them and provide them with a lot of assistance in the home. The difference is they're going to be getting 45 minutes twice a week versus 3 hours of therapy per day. So if a person really needs that much assistance and therapy, I'm first wanting to try to send them somewhere else where they can get more intensive therapy, knowing that I'm not going to be able to provide as much of that at home. Now, granted, COVID has changed things, and I get that, and I understand why people are bringing people home and not sending them to a rehab, and that's not what this conversation is about. That is an outlier. Got a patient today, family wasn't satisfied with the therapy care that he was getting and decided to bring him home with 24-hour supervision and home health therapy. So we're throwing everything at him to try to rehab this guy at home. So that is certainly an option, but you got to find the right provider, or else you're not going to have a good experience. So now mom was not homebound. Oh, that's the other thing. You have to be homebound. You have to be considered homebound in order to get home health. Now, what does homebound mean? It means it has to be extremely difficult and laborsome to get out of the house. If mom's a walkie-talkie and can hop up and walk out the door and there's no mobility issues, that's not homebound. Just because we think that they should be receiving the care at home doesn't make them homebound. Homebound truly means it is hard to get this person out, whether it be a behavior, anxiety, fear of falling, uneven terrain, all of these sorts of, no ramp and you're non-weight bearing, all of these things that make a person homebound. But say a person's not homebound, what are your options then? Well, you have the option of your Medicare Part B benefits, okay, which is a separate, so we have your Med A and your Med B benefits. If under your Med B benefits, you have now what's called the traditional outpatient. I had my total knee, I had my shoulder, I had a stroke, I've done all my rehab, and now I'm physically getting in the car. Somebody's taking me to a different building, like a doctor's appointment, where I'm having my therapy and they're billing me under Medicare Part B. So that's an option. There's a newer thing called Mobile Part B, which a lot of people don't know about. And if you don't, I would look around in your community, because somebody out there is doing Mobile Part B, I guarantee it. These are therapists who are opening their own businesses, or Fox Rehab is actually a big company that does Mobile Part B. So if you have Fox Rehab in your area, the person doesn't have to meet the homebound criteria. They can actually have a therapist drive to their house and do outpatient therapy in their home. It's a separate bucket of benefits. It's under your Medicare Part B benefits. So some people are choosing to do that now as opposed to going to outpatient. Okay, so that is also a different bucket of benefits. But say we have a person who, we'll go back to the example of somebody who was observation in a bed, outpatient in a bed, not admitted, did not qualify to go to rehab, acute rehab, did not qualify to go to skilled nursing because they were never admitted to the hospital. Your choices are the following: home with home health, where the family is providing 24-hour physical care, because obviously we needed that if we wanted to go to a rehab, right? Home with family caregivers assisting the person, home health therapy, or the person, if their needs are way more intense than requiring that a patient's family can take care of them at home, they need to go to a long-term care. They become private pay in the long-term care facility, which means I, as a family, am paying $180, $200 room and board to the facility for providing mom's room and board, but Medicare Part B is paying for therapy. So that's a runaround if you absolutely have no other way of doing it. That is typically the last ditch attempt, is that somebody has to go to a skilled nursing facility, like truly long-term care side, where you're paying room and board, plus Medicare Part B is paying for therapy. That is, we will exhaust every other avenue before we get to that one, because it is extremely expensive. But I've had it happen before, because that was the only way to take care of it. So how is Mobile Part B different from home health? Mobile Part B, so home health is under Med A benefits. It's a bucket of benefits under your Medicare Part A benefits. And Mobile Part B is under your Medicare Part B benefits, under the Part B outpatient benefit. The difference between the two major big differences is one's Part A, one's Part B. So Mobile Part B, Medicare A home health, okay? The other difference is under Medicare Part A home health, you have to be considered homebound. You have to be homebound. If you're not homebound, you don't qualify for Medicare home health therapy. You do not have to be homebound in order to have Mobile Part B. So people are choosing, some people are now choosing, because they don't want to be homebound. They'd rather access Mobile Part B outpatient benefits because they don't want the homebound criteria. Because way back when, the only way you could get therapy at home was if you were homebound. And that has changed by using the Mobile Part B therapy bucket of benefits. So I know that's a lot. I hope this was helpful. Let me just check and see if there was anything else that I wanted to say. I wanted to try to make this very practical for people to be able to see how just knowing that one piece of information from the beginning, whether somebody is admitted to the hospital versus an observation or an outpatient in a bed stay, can massively change the whole diagram of where a person goes. But if you think about a hospital as a clearinghouse, this makes it so much easier. What's a hospital's job? A hospital's job is to get somebody out of the hospital as fast as possible. That's the sole purpose a hospital has. They want people, that's expensive real estate. They want people in and out as quickly as possible. So a therapist's job in the hospital is to be able to go in and say, this one needs to go outpatient, this one goes home health, this one we recommend rehab, this one we're recommending skilled nursing, this person really needs hospice. And that's the role of a therapist. Now, some of the other team members that I really want you to get to know in the hospital are the case managers. You have to know the case managers. They are your best friend, because all of this conversation, the linchpin behind it is, what is that person's insurance? Because insurance dictates where we go. So those two pieces of information, knowing, truly understanding your loved one, what their insurance is and says, and understanding the policy, knowing, are they traditional Medicare? Are they a Medicare Advantage plan? Are they a replacement plan? Are they these are all these different things. You've got to know this, and you've got to be able to ask those questions, because just because I said Med A does this, if they're an Advantage plan, they, that plan delineates out, this is what you do, this is what you do, this is what you do. And that's what the case manager, that's their role, that's their job. Our job as loved ones is to be their advocate. Keep asking why. Why do you say she can't be inpatient in the hospital? I don't understand that. Why does she not? What diagnosis does she have to have for you to put her acutely admitted to the hospital? Why? Just be their advocate, but be their advocate in a nice way. So I'm going to end my monologue, and I'm going to open up the chat room. We're going to have the breakout session. The breakout session is not going to be recorded. This is for you guys to ask me specific to you questions if you have. I love doing this, so I hope this was fun for you guys.